I am the co-chairperson, he is the convener. Dr. SAMAR BASAK, sir is here. Dr. Mamta Singh. Come. And moderator Dr. Shipra Tripathi. She's not here. Achha, COVID. Okay, so let's convene the session. I call upon the first speaker, Dr. Prabhakar Singh. Role of amniotic membrane transplantation in acute ocular manifestations in Stevens-Johnson syndrome.
It's not coming here.
Okay.
A very good evening to one and all. The title of my presentation is Role of Amniotic Membrane Transplantation in Treating Acute Ocular Manifestations in Stevens-Johnson Syndrome and its long-term impact. There is a prevalent thought among clinicians that if a patient develops Stevens-Johnson Syndrome, his or her fate is largely dismal. And this is very natural to have this thought because in day-to-day practice, we come across patients with chronic sequelae of Stevens-Johnson Syndrome who end up having corneal vascularization, lid hyperkeratopathy, and severe dry eye. So can we actually change the disease course? Let's know about this in the further presentation. I will take you through a case of an 18-year-old female who presented with sudden onset rashes all over the body, photophobia, redness, pain, and diminution of vision for the last 10 days. She was a known case of seizure disorder and was on various anti-epileptic medications, and recent addition to her treatment regimen was lamotrigine, which was 6 weeks ago. And suddenly she developed sudden onset rashes all over the body. There was painful swallowing, and there were blisters all over the body. So on examination, systemically, she was conscious, coherent to time, place, and person. There was rashes all over the body. There were multiple flaccid bullae and purpuric macules with sheet-like epidermal detachment with multiple mucosal site involvement. So we made a diagnosis of Stevens-Johnson syndrome. The patient was admitted and was started on systemic steroids, that's pulse steroids. And this was the clinical examination. These are the ocular findings. Her visual acuity in the right eye was 3/60, and in the left eye it was hand motions with accurate projection of rays. The extraocular motility were full and free. There were scabs all over the face. On examination of lids and adnexa, there were scabs over the lids. The lid margins were deepithelialized. There was crusting at the lid margin with matting of eyelashes, and there was mechanical eversion of the lower lid margin and temporal ankyloblepharon. On examination of the conjunctiva, there was diffuse bulbar conjunctival congestion. There was blanching of the palpebral conjunctiva, and there were true membranes over the surface. There were desquamated sheets of conjunctival epithelium which was attached to the posterior lid margin, and that was also overhanging the cornea, and there were nasal and temporal symblepharon. As far as examination of cornea is concerned, the right eye showed diffuse punctate erosions, whereas in the left eye there was total epithelial defect with stromal edema, precluding anterior segment examination. This is the clinical picture of the right eye, wherein we can see that the red line shows the gray line, the green line shows the posterior lid margin, and the structure behind the posterior lid margin, this one is nothing but the deepithelialized conjunctival and corneal epithelium that is attached to the posterior lid margin, and the symblephra has been shown in yellow. So we made a final diagnosis of Stevens-Johnson syndrome with both eye grade 3 ocular involvement and planned for both eye membrane peeling with amniotic membrane grafting under general anesthesia or sedation. So here is a video of how we went ahead and did amniotic membrane grafting for the patient. First, we irrigated the ocular surface. Then the necrosed conjunctival membranes were peeled off the ocular surface, the palpebral conjunctiva. The symblephra was released, and the fornices were also swept to break any adhesions. Now, after placing the speculum in place, the amniotic membrane was placed over the surface. And once the amniotic membrane was spread all over the ocular surface, it was fixed with the help of a ring that was made out of an infant feeding tube. This facilitated stretching of the amniotic membrane not only to the ocular surface but also reaching the superiotemporal fornix not just superiotemporal fornix, but all the fornices. But the fornice that is more important to us is the superiotemporal fornice, fornix, because that is the place where the lacrimal gland ductules open up. So once the amniotic membrane is in place, stretching over the fornices, and now the redundant amniotic membrane, which is here, was reflected onto the lid margins to cover the deepithelialized lid margin. Post-operatively, the patient was started on following medications. And this is the clinical picture at day 7, wherein we can see that now the patient is opening her eyes comfortably. And this is at 2 weeks. Now coming to the questions that we had raised in the beginning, can we prevent the corneal vascularization? Can we change the disease course? We know that considering the fact that this is there is exuberant inflammation in cases of Stevens-Johnson syndrome, it has the potential to damage the limbal stem cells that lie deep down into the limbus. So definitely doing amniotic membrane transplantation at the early stage can prevent damage or mitigate damage to the limbal stem cells, and thus we can prevent corneal vascularization. And this is the clinical picture that is at 1 year follow-up. The cornea is absolutely clear. Now coming to the second question, can we prevent lid viper keratopathy? Again, the inflammation component can lead to exuberant deposition of keratin at the lid margin, and there is posterior migration of the mucokeratinase junction. Here in our patient, we can see that there is conjunctival scarring, there is meibomian gland atrophy, however, there is no lid margin keratinization and no lid viper keratopathy even at the end of 1 year. Now coming to this third question, that can we prevent severe dry eye? As I said while I was showing the video, that the superiotemporal fornix is the site which we are more interested in, because that is the site where the lacrimal gland opens up, and if there is scarring at that site, it can result into the obliteration of these the lumen of these lacrimal ductules, and the patient can land up into a severe dry eye. But these are the serial photographs showing active tear secretion in the right eye as well as in the left eye. So the take-home message here is that one should have a lower threshold for doing amniotic membrane grafting in patients with Stevens-Johnson syndrome, and acute inflammation, if it is controlled well in time and well in advance, can actually change the disease course. Thank you.
Yeah, nice talk. Do you apply it in the ICU setting, or do you take the patient to the OT usually?
So we had planned to take her to do it at bedside, but considering the fact the patient was having recurrent episodes of seizures, so we had to take her to OT.
Okay. And do you apply sutures, or you just?
No, we didn't apply sutures. Just the ring was there, and we just reflected it onto the surface. Once the amniotic membrane dried up, it stayed over the lid margin as well.
Onto the skin also?
Yeah.
Okay, and do you use cryopreserved, or you use?
Yeah, that was cryopreserved amniotic membrane. Actually, we had to procure it from one of the places that we.
You don't prefer fresh?
Yeah, fresh one. That was the cryopreserved one.
Cryopreserved
one which we used.
Okay.
Yeah. Thank you.
So how many times do you have to apply it, or once?
Only once we had done, and it was on day 12 of her symptoms.
Okay, and later on you didn't have to repeat the process.
No, sir.
How do you decide the endpoint? Like, this is now, I don't need to.
So during follow-up, we used to see, is there any surface deepithelialized, whether the surface is deepithelialized, because we cannot take that patient again and again to the slit lamp, also to the OPD. So we used to go to the ward, we used to instill fluorescent dye, we used to use blue filter of the IO in ophthalmoscope, and we used to screen for any epithelial defect.
Okay.
Fortunately, we didn't saw any epithelial defect, and it healed with over time.
So the amniotic membrane, size of amniotic membrane, when you wrap over the eyelid margin, so it is over the eyelid or just till the eyelid?
No, over the eyelids.
Over the eyelid.
Yeah.
So it's a very good procedure, and in acute cases, it really do wonders to go patient to shift into the chronic stage and doing lid margin keratinization and such a lid keratopathy and all the things, it prevents very well. But the irony, only the problem is that very few patients come in this stage and reported to the ophthalmologist actually. Usually patient reported to ophthalmologist in the late stage only, because in the severe setting, ICU setting, nobody is taking care of eye, and only they are doing the life-saving procedure and all the things, and eye get ignored.
Right.
So if it's reported early and it is done early, then the eye recovery is, I think it's a very wonderful procedure.
Yeah. Thank you.
You should read the paper of Dr. Daniel Gregory.
Yeah,
he was the one who started this from Philadelphia, USA.
Right.
Yeah, thank you.
So the classification system that I talked about, like grade 3, was from, thank you.
So the next Next speaker is Dr. Vijay Sharma. He will talk on autologous slit in unilateral limbal stem cell deficiency following alkali injury.
A very good afternoon to everyone. I will discuss autologous simple limbal epithelial transplantation in a case of unilateral limbal stem cell deficiency following the alkali injury. As we know, the SLET is giving the benefit of both conjunctival limbal autograft as well as the cultivated limbal epithelial transplantation, and it's also avoid the challenge associated with the both. So in SLET, we used to take the small biopsy from the limbus of the healthy eye, and it is divided in the distributed over the human amniotic membrane placed on the affected cornea. So advantage of SLET is it decrease the risk of iatrogenic limbal stem cell deficiency in the donor site, and it directly transfers the circumventing the need for the cell culture. And it also gives the opportunity to perform the biopsy, harvest and transplantation in one procedure. So these are the indication of SLET, like limbal stem deficiency secondary to OSS and excision, like recurrent pterygium, and the prior failed limbal stem cell deficiency. As all we know, the cornea is a non-keratinized stratified squamous epithelium, and it's usually undergoes the constant renewal by the limbal stem cells, and these limbal stem cells are present in the limbal epithelial grafts, that is present in the palisade of Vogt. So in the limbal stem cell deficiency, mainly the conjunctivalization of the cornea followed by the progressive vascularization and the scarring of the corneal surface is occur. The most common cause of unilateral limbal stem cell deficiency, ocular surface burn. However, in the bilateral limbal stem cell deficiency, Stevens-Johnson, ocular surface burn, and the allergic eye disease are there. So we'll discuss a case, 20-year-old female which presented to our clinic with a white opacification of the cornea, and she suffered an injury with the edible lime 7 years back. On examination, her left eye was within normal limit. Right eye, there was 3/60 vision, and the IP was digitally normal. We can see the irregular and hazy corneal epithelial surface, superficial neovascularization and subepithelial scarring. And we can see the 360-degree fronts of conjunctival epithelium encroaching on the cornea. And on a staining, there was a punctuate stippling on the staining. So there is a classification of limbal stem cell deficiency in a stage 1 and stage 2 and stage 3. In a stage 1, there is 1A, 1B, and 1C. We can see through this diagram, stage 1, one can see the 1A, the central 5 mm clear is central 5 mm is clear. However, the limbal stem cell deficiency is less than 50, 50 to 100, almost 100 in the stage 1, and the stage 2 central part is involved, and the limbal stem cell deficiency 50 and more than 50. Stage 3 is a total limbal stem cell deficiency. So in my case, the grade 1 symboliform was present, which with a limited sporadic shortening. So this was case of unilateral stage 3 limbal stem cell deficiency with a grade 1 symboliform. So ideally one should do the SAMAR test before proceeding for the simple limbal epithelial transplantation, and the ultrasound was done, which was normal. So these are the indication. Ideal case is to wet ocular surface and without any adnexal pathology, minimal or no symboliform, cleared to translucent underlying stroma. These are the contraindication: dry ocular surface, blind eye, disorganized anterior segment, and the uncorrected adnexal pathology. So we went ahead with the anterior segment optical coherence tomography, which shows the underlying stromal thickness infrared photography of the cornea on ASOCT, we can assess the degree of opacification of the underlying stroma. However, in the simple intra-segment photograph, you cannot judge the underlying stromal thickness. So, using the infrared imaging of the intra-segment opacity, you can identify the stromal opacity. So, however, the corneal thickness was very thin. It was 427 and minimum was 420 with the conjunctivalization of the cornea. So, residual stromal bed after the Panus excision, it's about 280 is the clear stromal bed was there. So, it was a very thin cornea. So, we counsel the patient about the possible need for the additional surgery, and the goal of surgery was clearly explained to the patient. Patient might require the penetrating keratoplasty. So, a preoperative ASOCT should be done to delineate the area of thinning and the finding the plane of dissection to flush the limbus and moving inwards. Alternative option has to be kept. Surgical insight to address the symblepharon extended till the limbus. This could interfere with the placement of eye speculum intraoperatively, and placement of BCL is difficult in these cases. So, single stage surgery to address the limbal stem cell deficiency along with the symblepharon. So, our plan was the conjunctival autograft with the simple epithelial transplantation. So, how to harvest the limbal stem cells. So, just 2 by 2 mm of stem cells is identified at the limbal zone, and it has to be dissected using the crescent and the blade. One should avoid the marking, as marker pen contain the alcohol that can damage the limbal stem cells. So again, after the donor harvesting, one can do the Panus excision and the symblepharon release. So after releasing of the symblepharon, the 360-degree conjunctival peritomy has to be done, and the carefully symblepharon has to Panus has to be removed. So one can see, one has to find the proper plane where you can dissect the this conjunctivalization of the cornea. So this was a scarring, scarring was very deep. So initially I could not find the plane. So I just debulk the cornea and try to find the plane. So using the blunt dissector, I just find a plane. So carefully dissect the cornea, as we already saw the ASOCT, there was a very thin stromal bed. So after the dissection of this opacity, just apply the amniotic membrane, epithelial side up, stromal side down, and then just apply the fibrin glue. And this amniotic membrane should tuck inside the conjunctiva, and this was the limbal stem cells, which is cut in the multiple pieces and which should be applied at the mid peripheral area, and the glue should be put over the limbal stem cells. So in this limbal stem cell should be pigment side should be up, stromal side should not be up.
Please sum up. Your time is over.
Yes. So post-op day and post-op to 1 week, we can see the settling of the limbal stem cells. So donor side of the post-week which are healthy. Post-op regime is a normal prednisolone and the antibiotics should be given. The BCL should be removed at 1 week. Thank you.
So very nicely managed case. So SLATE is really a boon in such type of cases. So one thing just I want to know, if in these cases of extensive symblepharon, what would you do to prevent the forming the symblepharon?
Yes.
Again? Because
so in this case, I just taken the graft, conjunctival graft from where I have just taken the limbal stem cell. At that point of where I have taken the conjunctival, and I have put that conjunctival in the opposite eye where the symblepharon was there. So ideally, conjunctival graft should be done at the site of symblepharon. It is grade 1 or less than.
Also in many such cases in grade 1 SLATE, grade 1 limbal stem cell deficiency, you don't even need to take autologous grafts, you can just
Put the conjunctival
scrape
yes.
the pannus and allow the epithelium to epithelialize, and if it keeps coming, you can do a procedure called as SSC, described by Dr. Dua, which is sectoral conjunctival epithelectomy. You just scrape it and allow the rest of the epithelium to take over. So
Yes.
you need not do actual grafting of stem cells
Yes.
in grade 1 LSCD cases.
Yes.
Just scrape it off. Yeah. Okay, nice talk. Thank you. Third one is Professor Dr. Lionel Raj. He's going to speak on drug repository contact lens, hasten healing and minimize antimicrobial loading doses in bacterial keratitis, a randomized control trial.
Good evening, chairpersons and dear friends. Warm wishes from a place called Tirunelveli, closer to Kanyakumari, all the way from there. So I do not have any financial interest or relationship in the following topic, which relates to drug depository contact lens, a novel one that prolong antibiotic corneal contact time in bacterial keratitis, results of a randomized control trial. Up to 5% of all blindness are due to infections of the cornea, and microbial keratitis accounts to nearly 1.5 to 2 million cases per year. Prevalence is as high as 11.3 per 10,000 population in South India, and presently loading dose concept of antimicrobial agents in the form of ocular topicals are the preferred treatment options. However, precorneal factors and anatomical barriers negatively affect the bioavailability of the drug in the lesion. So with this background, we propose to study the efficacy of novel therapeutic contact lens that can increase the overall contact time of antimicrobial agent, serving as a drug reservoir in subjects with bacterial keratitis. It's a randomized open label clinical trial. 40 eyes, conventional sample. They were grouped in 1:1 ratio. Group 1 received only topical antimicrobials. However, Group 2 had a drug depository contact lens with a central reservoir along with fenestrations to enable capture of every time applied antimicrobials. So we followed up on 12th hour, days 1, 3, 5 and 14. Pain was also evaluated in a 10-point scale. And a separate study on availability of the drug in the central reservoir was also analyzed over time curve. This is the proprietary design. You can see dual base curve design, which forms a central reservoir for drug and fenestrations which enable capture of every time applied antimicrobials. The results, corneal infiltration or the bacterial keratitis severity scores on presentation in Group 1 and Group 2 were comparable. However, resolution by 12 hours by day 1, day 3 and day 5 was comparably better in the contact lens group than with drug alone group. This is a representative case of bacterial keratitis, a central lesion keratitis with an abscess. You can see the drug depository contact lens with fenestrations, and this is by 12th hour, by day 1, day 3 completely resolved, and day 5 and day 14. Another case example wherein a paracentral lesion, staphylococcus, which healed before day 3. You can see effective healing by 12th hour and good healing by day 1. The visual acuity also, there was a mean of 1.5 line improvement in vision noticed in day 1, which improved by another line in day 3 in the contact lens group. Significant visual acuity gains were observed in drug depository contact lens group in days 1 and 3 respectively. Pain was also comparable at presentation between either groups. However, there was a gross reduction in pain in the first 3 days in contact lens group when compared to drug alone group. Similarly, reduction in haze and AC reaction was also more pronounced in the first 3 days in the contact lens group. Larger sized ulcer, this is a gram-negative ulcer which healed within 14 days effectively within the first 5 days in contact lens group. As I said, The drug retention in the central reservoir was studied separately, and the drug was found in the precorneal space up to a period of 4 hours. So poor drug availability is a major concern associated with ocular dosage forms. So in this study, we aim towards retaining the drug in the precorneal space by using a very highly specified depot contact lens. The fenestration in the lens enabled capture of every time applied antimicrobials. As we clinically documented resolution of infiltration, improvement in the bacterial keratitis severity score, the pain resolution in the first 3 days, we recommend that the treating physician may remove the lens after 3 days, but the first 3 days are crucial and the lens need to be there in place. Further studies we have taken up, and we are also working on extension studies to evaluate reduced topical loading dose burden also for additional safety and efficacy data. To conclude, the drug depository contact lenses may be indicated for therapeutic use to promote effective healing and pain relief in cases with bacterial keratitis. The concept of using novel drug repository contact lens over the lesion is effective in prolonging corneal antimicrobial availability, which can affect the overall outcomes in management of bacterial keratitis. This can reduce the treatment burden of antibiotics, burden on the medical staff, improve patient tolerance, and also reduce drug toxicities, and may change the present practice pattern of loading dose concepts. What is known? BK causes unilateral blindness in developing countries. There is an unmet need for effective treatment option as to drug delivery. An intense loading dose is required. What the study adds, drug depository contact lens extends corneal lesion, drug lesion time, and healing in bacterial keratitis. I thank you for your attention, and you can find this published article in British Medical Journal. Thank you one and all.
Sir, where do we get this contact lens?
Yes, it's a proprietary thing, and we are working for marketing license. Maybe in a month it will be available in the market.
And it's like a rigid lens?
It's made of aquafilcon A material, and you can, it is not a rigid lens. It's a kind of soft lens, almost similar to that of a Rayner foldable IOLs.
And the frequency of the drops is reduced in such cases?
It's
or
reduced.
You have to
It's
dip
reduced.
It in the drug?
That's what the methodology has not been extensively described in the presentation, but we had it every 2 hours in the first 2 days, followed by 6 hourly, that's 4 times a day in the next 12 days. But now we are working on even further reduced burden concept, where there are 3 arms, the third arm getting only 4th hourly antibiotics right from the beginning.
So is this the empirical treatment that we are giving here in all the cases?
Is it?
Is the empirical treatment we are giving here a broad spectrum antibiotic we are talking about?
Well, what we do, we have microbiology unit associated within the hospital. So first what we do is, when we see a suspected cases of bacterial keratitis, we do a scraping. We don't start with any antimicrobials. Then based on the gram staining properties, in this particular randomized control study, we used only a 4th generation fluoroquinolone as a standard agent. However, presently we are also working on amikacin in gram negatives.
Question, sir, regarding this. Although this is a randomized control trial, sir, but those 2 study groups, were they comparable in terms of grading of ulcer?
Yes, that's what I said. At the baseline, they were comparable.
And if we have to continue this contact lens for a longer period of time, then do we need to change it?
I said in this particular study, we continued for 14 days without any toxicities of the lens. But then, since we find good response within the first 3 days, we recommend the physician to use it for the first 3 days, and after 3 days, whether to continue or to discontinue based on the clinical evidence of healing, it's up to the treating physician.
Just like if we have the contact lens over the surface, then staining of ulcer and all this, does it get difficult a little?
You can remove stain and reapply also.
Reapply, and then when we have removed it, we have to keep it in like antibiotic solution or something.
But no. The contact lens cassette solution is available.
Yeah, right, and that will be having the typical soft contact lens washing solution.
No.
That is
That's
different for this.
Yeah.
Any experience about in fungal ulcer?
Yes, we are also trying on some of the fungal keratitis, but then we are making a slightly larger fenestration size. So that is now, I would say, generation 2 lenses what we are working, because most often fungus what we see in our area are dermatitis fungus, and natamycin is the drug of choice, which are polyenes. They are large chains. They are suspensions, not clear solutions. So retaining a polyene on the surface through the fenestration may be a challenge. So we are trying to make a larger fenestrations for fungus.
If it is getting retained there, then probably over the surface, if natamycin is staying for a longer period of time, will it cause any ocular surface?
No, we don't know. We just have some case reports on fungus. We are not an authority to right now talk on fungus.
Can we immerse the lens in the antibiotic and then place it? So we don't even
no. That is for a sustained release property. Here we want to have a potential precorneal space, like an antimicrobial lake, to retain the drug in the space.
Can we use any semiscleral contact lens for this, sir?
Can we use
semiscleral contact lenses that we use in cases of dry or
but
something?
But we don't retain drug for a longer time.
They do not have that fenestration that you.
Not alone that, they just on the top of the surface, the epithelial surface, we don't have a potential space, a lake. So this is a dual base curve designed to make a lake.
So usually in an infection, we try to avoid any contact lens on the eyes. We want to remove it. So how does this work against that principle?
Well, let's take an example. We have a burn. It's better not to have something on a burn, dermal burn. But if you can retain some moisturizing thing, or if you can retain some active ingredient over the burn, then yes, we also use some wet gauze or something. It's something similar. Why do we not want a foreign body? It's a foreign body. But at the same time, this foreign body is meant to retain drug. It's like applying a bandage. You want to have medicine, you want to have the medicine stay there for a longer period of time.
I think also depends on the material, which prevents infection.
I wouldn't tell the material property outweighs here. It is just the drug which is needed stays there for a longer time.
I want to ask a question.
Excuse me, sir. Recently I have come in a contact of a product that I asked you that umbilical cord I am working on. So what they are doing on amniotic membrane, they are coating with PHMB. So have you think of or plan of make it like coating of PHMB, that whether we can use it for acanthamoeba in?
Yes, PHMB is a known agent that can be that acts against the trophocytes of acanthamoeba.
Yes,
that's for sure. But can you retain PHMB on umbilical cord material or on the amniotic membrane surface for a longer time? That becomes a challenge.
That's what I am asking. Like, can you use it in contact lens that may help for acanthamoeba cases? Because we don't have any definitive treatment.
No, we can directly use PHMB over this lens.
Pardon?
We can directly use PHMB
over the lens.
Over the lens, yeah. Why do we need any dispensing agent like amniotic membrane here?
So suppose I have one acanthamoeba case. So I can put 1 drop of PHMB in BCL and I put it over there?
Not BCL. This is a highly specified lens. So you can use this lens.
So what kind of lens should I use in this case?
Yeah, that will be available in market very soon, within a month.
Okay.
Yeah.
So that will be for the first time I have to put 1 drop of PHMB and then like that, or like I have to put it?
Either way. It has fenestrations. they observe.
Right. Okay, thank you.
Any criteria for ulcer size in which these lenses can be used?
Sorry?
Any criteria for ulcer size?
Ulcer size, yes. We had ulcers of different sizes, but this series it is 2.78 was the average ulcer size, but we also had over 4.
Okay, sir, very excellent presentation and very informative. So now we will call upon Professor Dr. Vijay Kumar Sharma for next talk. He will presenting managing high-risk keratoplasties. Professor Dr. Vijay Kumar Sharma. Is not here. So the next speaker is Dr. Mamta Singh. She will present post-operative complication of penetrating keratoplasty.
This is for the another session. Go to the previous. Oh, this is for the other session, sir. No, this is for the next session. To the organizers for this opportunity, I will be talking about the post-operative complications of penetrating keratoplasty. Although we have shifted to lamellar keratoplasty for all the vision-related things, but when it comes to ocular saving, mostly we are dependent on penetrating keratoplasty, and that is the reason precisely why we need to know this procedure in details. So these complications can be divided into 3 parts, those occurring early in first 7 days, intermediate in first 3 months, and late beyond that. So in early phases of keratoplasty, we need to think of some problems related to wound, epithelium, AC status, etc. And we'll see few of them in pictorial manner. Exposed suture knot, although this is a case of old graft, but we can see this exposed knot here. And we can see something like this on the very first day after surgery. And this knot doesn't only make the patient symptomatic, but it also acts as a nidus for infection. So whenever we are tying the suture, we need to follow the proper protocol of suture tying. We need to consider the knot size, make it as small as possible. If 3:1 is larger, then go for 3:1:1 tying pattern. And cut the suture, not neither very close to the knot, not very far off, just the adequate size. And whenever we are trying to rotate it, we should rotate it into the stroma, not just beneath the epithelium. Otherwise, when the corneal edema will go down, probably the knot will get exposed. Then, if we have something like this in first post-op, then we can try rotating it even under slit lamp view. But if that is not successful, we need to go to OT and replace the suture. Similarly, loose and tight suture. We can see on the left side there is one loose suture. On the right side, we can see the tight suture. And loose suture is not going to serve any purpose other than being a source of infection, vascularization, etc. And tight suture is going to induce astigmatism. So in these cases, what we should do first, while tying the suture, we should adjust the proper suture tension, consider the graft edema, consider the tissue edema, even the scleral bed also we should consider. And when we are finishing the case, we should always try to form the AC with BSS, preferably if the iris is not very flaccid. Otherwise, the AC will appear to be well formed, but once the air will get absorbed, the sutures will appear loose. Although this problem is lesser with nylon suture. So if we have something like this in early post-operative phase, we can replace the suture. But if we have it in the later phase, like beyond 3 months and so, we can simply remove the suture, because beyond 3 months, most of the tissue adhesion has already occurred. Sutural infiltration. We need to differentiate between inflammatory or immune-mediated infiltrates and the infective infiltrates. Immune-mediated infiltrates, as we can see it here, they are multiple, mostly seen on host side. They are not associated with epithelial defect, and they respond to steroid. Iris incarceration, again something like this we can very well see in cases of therapeutic keratoplasty or those cases with adherent leukoma. And we need to rule out the active leak with Siedel's test. And something which I always follow, whenever I'm trying to pass suture in these cases, I lift the wound edge and then only I pass the suture, so that I'm assured that the iris is not there with the suture. This was one case of adherent leukoma, and iris was completely plastered to the cornea, and we tried saving it, but there were multiple cuts. On the very first day, we saw that there were multiple iris pigment clumps here. But on the oblique view of the slit lamp, we could see the iris well behind, and the AC was quiet. So we just continued the patient with the standard treatment, and the patient responded very well. So this is something we should keep in mind, that whether it is frank iris tissue or just the pigments there. AC status. If AC is flat and there is an active leak, we need to take the patient immediately to OT and reform the AC. But if AC is shallower or moderate depth and there is a minimal leak, we have time. We can take liberty, we can put BCL, wait for 24 hours. If the AC is formed in 24 hours, we can, wait and put the BCL, continue the BCL for another 2 days, and then try removing it. But if the AC is not formed, even with that, then better to take the patient for resuturing. Epithelium management. This is particularly more important in cases where the primary pathology is important, like in cases with compromised ocular surface. Like the upper one, this was a case of silicone oil induced keratopathy, and the silicone oil was still there in the posterior segment. It was practically oozing out. So obviously the epithelial problem is going to be there, the healing problem is going to be there. Similarly, this was a case of Sjogren syndrome. So whenever we have a primary pathology like this, we should go for good tissue, preferably not with an epithelial defect. And we need to stain this graft regularly to ascertain that the epithelial healing is going on or not. What I practically follow, if the epithelial defect has not healed by 1 week, I go for BCL application. And if it had not healed by 2 weeks, then I go for tarsorrhaphy. That is my pattern. IOP management. If we have a low IOP with shallow AC, always first rule out any leak. But if there is no leak, then we should rule out choroidal detachment, retinal detachment, or ciliary shutdown because of uveitis. If we have a high IOP with shallow AC, we need to think of pupillary block glaucoma or something which is like pushing the lens iris diaphragm forward. So we need to manage accordingly. Graft infection, this was one case of therapeutic keratoplasty. We did the graft here, and on the very next day, we got a picture like this. It came out to be pseudomonas. We did a repeat grafting. Somehow we saved the eye, but the patient lost the vision. So in these cases, we have to make sure, especially when we are going for repeat grafting, we have to make sure that we are using cornea from a safer source. Like we need to rule out the primary infection at that point. And we need to consider the color and everything about the storage media. Antimicrobials, as per the culture sensitivity report, if it is available, and withheld corticosteroid if possible, at least in the early period, because here the aim is not visual gain. At times we need to differentiate between infection and inflammation, like this was a very large size therapeutic graft, and on the second post-operative day we got a picture like this. In the middle picture we can say we had this white granular appearance. So granularity is something like which goes more in favor of inflammatory exudate. So we went ahead and continued the steroid, and this patient responded well with the steroid. AC inflammation, this was again a case of adherent leukoma, and the pupil was not dilating, and we did a triple procedure, but the initial 10 days was very bad. The graft was not at all getting cleared. We gave a bolus of steroid. Finally the graft got clear, and then we saw that there is a lenticular matter, lens matter behind the IOL. We aspirated the lens matter, and finally the graft got clear, sure. Late post-operative complication, the primary is graft rejection. All the more very important in cases of high-risk cases, we need to make the patient aware of RSVP. Can be epithelial, stromal, or endothelial. Epithelial rejection mostly responds to topical steroid, but stromal and endothelial, we can go for IV methylprednisolone with IV DEXA or IV DEXA along with systemic and topical steroids. Post-keratoplastic glaucoma, more common in aphakic pre-existing glaucoma, triple procedure, vitreous loss, intense inflammation. These cases, they do not respond very well to medication, especially if the angle structures are already collapsed. There is a peripheral anterior synechia. So we need to go for TRAB, GDD, or cyclodestructive procedure. This was one case of tectonic keratoplasty where we had initial melt here at 12 o'clock. So we went ahead and did a scleral patch here. But we saw another leak here, but when we explored this, we found that it was just a minimal leak. We put amniotic membrane grafting, we tightly closed it with tenons and conjunctiva, and ultimately it did well. This is ultimately graft failure. Thank you so much. Yeah.
Thank you. Very nice collection of cases and essential lecture in this era of lamellar keratoplasty. We should not forget penetrating. Do you consider mixed suturing, like 8 sutures of
continuous
continuous, yeah, because it takes care of most of the problems.
Yes, sir.
Yeah.
In therapeutic cases, I always go for interrupted, but otherwise, optical I go, sir. I do it.
That helps in
that helps a lot.
Gives a balance of both.
Yes, sir, definitely.
Thank you. Thank you for attending the session.
So thank you to very nice presentations. Thank you all the speakers and all the audience. Thank you.
We invite for the next session to take over. Thank you.